what makes us so sure that there is actually a comparability between the treatment of MS and the treatment of Alzheimer's?
There isn't. I mean, they're not the same, needless to say. But I think that, it's an interesting data point. TNF inhibition seems to work in every disease that steroids work in, or steroids at least work in every disease TNF inhibition works in, but you have this opposition in MS that's unique and interesting. It's not the only disease where TNF fails. TNF, for example, doesn't work in asthma. Well, steroids work very well in asthma. Like I said, it's a shotgun, so the rifle sometimes can't be used, but I think the rifle's inability to tackle a brain disease is somewhat interesting of a data point. There's also a whole number of other examples where other attempts to lower TNF in the brain have been tried in Alzheimer's and have failed, again, through indirect means. So we'll see.
If you wouldn't mind, could you maybe point me to some studies where I would be able to read for myself and identify that the approach that INmB is trying for Alzheimer's is actually a shotgun approach and not a rifle approach for Alzheimer's that wasn't tried before?
I'm not really sure what you're asking, but my research is available on my GitHub, and you can go to INmune site if you want some of their research.
You are comparing a rifle approach against a shotgun approach. What makes you think that the approach of INmB isn't a rifle approach, so a specified, focused and targeted working approach for Alzheimer's?
Well, I mean, the first thing is there's no evidence that TNF-alpha matters at all in Alzheimer's, and there's no evidence. In fact, there's just as much evidence that suggests that you don't want to block TNF-alpha in Alzheimer's, and blocking it would hurt the patient. So I think that, you can imagine it's a rifle, you can imagine anything, but the simple reality is there's no evidence that points it in that direction. So I'm sure the company thinks they have the perfect drug, but the stock market and everybody else thinks that they don't. So the onus is really on the company to prove what it's got, not the other way around. Drugs don't work by accident. You can usually safely assume a drug doesn't work. So, I think that, if they have something that works, the phase 1 data maybe would have been better, or they would have had, partnership interest or investor interest in their product. These things by themselves aren't all dispositive of anything. There's many drug companies that had no interest from their peers, no interest from Wall Street, and then they became the belle of the ball. Cinderella happens sometimes. But I feel like, without phase 1 data that puts the drug on good footing, without a scientific interest in TNF-alpha, TNF-alpha has been around 25 years as a drug, 50 years as a concept, and not many people have gotten that excited about this idea. They're not the only research people in the world. They're a very small group. There are lots of people that have talked about this over decades, and nobody's had the interest to do what's a $10 million trial. That would have been very limited. So I feel like, if you take everything together, it feels like there's nothing here. TNF-alpha is just one of thousands of proteins involved in the immune system, and the chance that it is the key that unlocks the kingdom is just, it's foolhardy at best. And there was a TNF trial done, and it did not work. So there's a small trial done, and when drugs work, they work. And even in small trials, you'll see a substantial difference. And this is not the case. And you have to go jump through a lot of mental hoops to buy the bull story of INmune, which is like hanging by a thread, that somehow Enbrel won't do the job, but this drug will, because it spares TNF-R2 binding, which is just like I said, a bit of a, you have to tie yourself in knots to believe this. But again, some people believe, they want to believe. People join cults all the time. I understand that people want to make 10x their money or 20x their money, but it's just not something that is in the cards, I don't think.
If they're not able to make this work, is the company effectively worth zero?
I think so. I mean, they have something for epidermolysis bullosa, lysis bullosa, which is a very rare disease that is also very competitive. You know, so is there a possibility that they move forward with that drug? Yeah, it's possible. But it feels like, you know, it feels like that's fairly unlikely. And they basically just have to recap and reboot, which, you know, is probably what's going to happen. And they'll survive. They'll have a new life as a EB company, trying to beat all of the EB, tons of EB, you know, treatments that are out there. EB is a big market, and there's plenty of companies trying to do EB, and, you know, we just don't know how they'll do. I haven't looked at the drug in too much detail, but it doesn't seem like most people are excited about that one. But it is possible that, you know, they'll do well in EB.
Even if it was successful, I don't know if you would like know this off the top of your head or if you've done a model about it, but like how much revenue would they realistically generate from this drug if they got through all the hurdles?
I mean, Alzheimer's is pretty big, you know, it's one of the world's biggest diseases. I don't see why it wouldn't be, you know, a major opportunity. You know, certainly not a small thing. But I will say that Biogen's failure to succeed in Alzheimer's is a little concerning. So Lilly's as well. There's just a bad taste left in people's mouths from Alzheimer's because of the way, I guess, Aduhelm was rolled out. People were very upset about that. So there's just this feeling that nobody wants Alzheimer's drugs because of this, but that feeling will go away. And I think, to me, pretty clear that, you know, there's a big market here. You know, I can't find another disease where steroids. So the question is it possible that inhibiting with TNF is better than inhibiting with steroids? I actually can't find a disease where inhibiting with TNF works, but inhibiting with steroids doesn't work. Because like I said, I really do think that TNF alpha inhibition is subsumed, amongst other things, within steroids. That's kind of one of the primary ways steroids kind of work. That's why TNF, you know, was sometimes called a supersteroid. You know, steroids also cause metabolic disturbances. And, you know, so you gain weight. They cause some psychiatric disturbances. And then they cause some osteoporosis. So that's why you don't generally take steroids for very long. But they don't seem to cause any cognition issues. Is that there is a TNF-R1 knockout, and TNF-R1 knockouts don't have cognitive impairment, which is really interesting. They just get periodic fever type syndrome. They could delay a readout. You could easily see them delay. Need more time to understand the data. It's interesting. Inflammatory cytokine levels correlate with amyloid load in transgenic mouse models of Alzheimer's disease. Kind of tells you that they're cleaning it up. You know, the instant impression is that that's a bad thing. That, oh man, that all this amyloid is there, and now all these cytokines show up to clean up the party. The cytokines must be causing the damage. Well, maybe they're actually helping. They could be neutral. You know, there's also homeostasis. I mean, you can knock out TNF, but what do you think is going to happen? You're not knocking out the signal that's causing the inflammation. So that's why TNF, for example, I mean, rheumatoid arthritis, you don't get 100% disease response because the body's got other ways to deal with the inflammation.
Is anyone in here talking INmune?
Yes.
I am cautiously and speculatively positive on INmune's potential for positive readout. The prednisone theory, like your way of trying to predict that it's going to fail or that it shouldn't be able to improve cognition or to slow the decline, feel like is not like the strongest one you could be making, and like has a bunch of pitfalls.
The good thing about medicine is that the burden of proof is really on the medicine. It takes a huge amount of evidence to fight the gradient of impossibility. You know, making a drug is really, really, really hard.
And in Alzheimer's.
Yeah, it's pretty difficult. So every time you stack up a piece of evidence that works against you, and I think there's no doubt that, you know, if you read any amount of if you have any understanding of steroids, they drop TNF quite a lot. So, you know, giving a drug that drops TNF quite a lot is not that different from giving steroids. Is it perfectly the same? No, of course not. But, you know, in autoimmune disease, if you've been following the space as like the pharma bro that I am, I follow every drug, and I have for a long time. You know, most of these autoimmune diseases and drugs are kind of a dime a dozen. They all kind of do the same thing and they all work the same way in all the same diseases. It's very bizarre when a steroid, for example, doesn't work in Alzheimer's. The only conclusion one can draw is that Alzheimer's is not an autoimmune or autoinflammatory disease, because otherwise steroids would have worked. And for everything that steroids work in, which is literally every single autoimmune and inflammatory disease, then there are a subset of those diseases like TNF, TNF responsive diseases, antibody, like CD20 responsive diseases, some that are even more rifle shots, et cetera. So that's kind of the way I'm thinking about that. But the good news is I can be completely wrong on that. And there's other problems with INmune that will result in its failure, most likely.
That's sort of my point, is like, obviously it can still fail. The odds are it still will fail. I just sort of intellectually have sort of disagreements with a bunch of aspects of using prednisone or using glucocorticoids.
Well, go ahead.
Say that likely. Well, like, for one thing, it's like glucocorticoids, obviously they're very anti-inflammatory, but you would have to acknowledge they're also like damaging to tissue and can be even in the short term at higher doses. And they're associated.
Which tissue?
Well, like even neurology, like the hippocampus. Like if you give rats and even humans prednisone, it shrinks their hippocampus, for example, or their amygdala. Like it damages that tissue. So what do you think about that?
Yeah, I don't know. I think lots of people take steroids in the long run, and the main problems are metabolic and other issues. I don't think they're too CNS toxic.
Okay. I mean, even if they were just metabolic, there's something there causing the shrinkage of like brain structure that is obviously.
Maybe you could give me a paper that shows that, because I don't know, that doesn't seem, in my years and following this stuff, that doesn't seem like the main.
Yeah, no, I have a bunch of papers here. I mean, it's not, maybe not the main issue. I'm just kind of throwing it out there, something that could sort of go against your theory of cortisone and cortisol and those things.
Well, then I would just say that TNF would do the same thing.
Right, but like then you get into, okay, so there's a bunch of studies, to your point, showing that prednisone and all the other glucocorticoids don't work in Alzheimer's, and there's actually a bunch of studies that show that it impairs cognition and memory. Then like what about the fact that something like Humira or Enbrel, at least in the patients that have, rheumatoid arthritis or whatever else they're treating, it's lowering their risk of getting Alzheimer's by something like 50%, 70%.
Whoa, where'd you come up with that data?
That's like a 40,000 patient meta-analysis. It's in neurology. I can send that in here too.
No, I'm aware of it. Do you think that data would replicate if it was tried again?
It's observational, so it's backward looking. You mean if it was an RCT or something?
Yeah, I mean, if you went to a random health, authority that had this kind of data and you tried it again, would you see the same trend? Like,
would you be able to do an observational study that found that same trend, like looking at like insurance data for replication? Well, it's not like replication because it wasn't an RCT. It's an observational backward looking study.
You could replicate the observation.
Oh yeah, then yes, I think so. And there's more than one study that's been done on it.
It seems like it would be 100x if that was causal and useful.
What would be 100x? Humira?
The stock, yeah. No, INmune.
Well, I was talking about Humira there, and I was just using it as a juxtaposition versus prednisone and the glucocorticoids.
Yeah, I mean, if that's a real signal, then, INmune's going to go up a lot. But I think that science is littered with these things kind of not being real.
What I'm getting at is there's a clear, like, almost opposite effect that's been shown between like a prednisone anti-inflammatory action and like a Humira Enbrel type anti-inflammatory action.
Yeah, I can't trust the observational stuff. It's too retrospective.
It's literally like actuarial data from health insurers, and is like, I forget, it might have been like 50 million. I think I understated it before. I think it was like 50 million patient data from 50 million.
Did they prospectively have this hypothesis, or did they get it after the data?
No, I've said no, it's the third time. This is a retrospective observational study. It's a correlation. It's a correlation study, and I'm only using it to argue that TNF inhibitors don't have the same actions as glucocorticoids.
I don't think you could argue anything from retrospective data. This is why we do studies, right? We have a hypothesis and test the hypothesis. You don't do it the other way around.
Okay, yeah. Well, there's at least no data, either type of data or any type of data showing that Humira or TNF inhibitors are impairing cognition, which it's extremely clear that corticosteroids impair cognition and memory in humans and in animals.
Certainly in Alzheimer's.
And healthy. I've got multiple studies if you want that too.
Sure.
There's literally there's a well-known steroid dementia syndrome. You retain less information. It's cortisol. I mean, it makes sense even from a first principles. It's the stress hormone of the body. It impairs your cognition and memory.
Yes, I suppose so. I'll wait to see that data. But irrespective, it feels to me that, at least, I guess if you have TNF as the downstream response to, it's a downstream effector of steroids, that's one of its principal mechanisms of action, amongst others. You are, certainly steroids have, like I said, it's a shotgun approach. It's sort of a knockout for the immune system. If you look at the Enbrel study in phase 2, there's no benefit there in Alzheimer's. The next thing that's sort of annoying is, or frustrating, is that there isn't much data from the phase 1, but the data that they did give us wasn't very good. For example, the cytokine panel was only...
We can get on.
Okay, hold on. Just listen for a second. The cytokine data that they did give out was a 15% reduction in cytokines, which is to me, just noise. I wouldn't have shown that slide if I were them, but maybe they just don't have anything else to show. But a 15% reduction in a panel of cytokines is really, really, really kind of meager, and almost like grasping at straws, I'd say.
Yes, I would agree with you there. And also there's a bunch of things you could say about the phase 1 data that make it incomplete, and there's some causes for even kind of curiosity on why they didn't release certain cognitive endpoints and whatnot, because they obviously just should have been as transparent as possible. That's obviously a separate issue. Getting off of my main qualm with anything you said about it was just using prednisone as the reason for why it couldn't succeed. But I guess we can either stop going down that path.
Yeah, I mean, I stand by it. I think there's the work I did on kind of what works and what disease, is, I think, interesting. TNFs don't work in MS, for example.
They make it work.
Yeah, and that's not a wonderful thing if you're trying to treat the adjacent brain disease.
Yes, someone really into INmune BIO and had looked into the science and is buying into what INmune is saying. And if all the, preclinical studies are true about soluble TNF versus transmembrane TNF, they would say that soluble TNF is the neurodegenerative and demyelinating force, and that transmembrane TNF is actually myelinating. And you can type in transmembrane TNF and myelination, and there's dozens of studies showing that, at least preclinically.
Yeah, that seems like a stretch to me.
It's not one group anyways. It's literally
it just seems like a really, really big stretch, because I think that there's a lot going on with Alzheimer's, and transmembrane TNF, subtle difference between TNF-R1 and TNF-R2, isn't it?
I'm just more saying why TNF inhibitors could cause MS. I do believe that's probably the reason.
I think that's jumping through hoops that are too much for me. I mean, the simplest reason is they just don't work.
Well, why would they cause MS if they didn't work?
They don't cause it. They have a slight increase.
Yes, they increase the prevalence of it. So why would that be?
No, they don't increase the prevalence of it. There's
multiple studies.
There's more flares. There's one study. There's it's PubMed 316304445. There are more flares in MS patients. And the answer there is because soluble TNF is important. we have it for a reason, and just blindly inhibiting it is not, doesn't make sense. And in the brain, it could be very protective, and it's very dangerous to do this in Alzheimer's. And in fact, I think this drug will make it worse. I actually think they'll show that placebo beats drug here, which is for a lot of people out of the realm of possibility, because again there's when you want to buy something and you want to believe that it works, you're focused on that and interpreting all the evidence the way you want. But if it's worse in MS, prednisone's worse in Alzheimer's, and you're now doing TNF and Alzheimer's, I'd bet money that it's actually worse than placebo. Not just not better, but makes it worse than placebo. And then there's not having COX-2 work or NSAIDs. Those are downstream of steroids too.
I would just wanted to take sort of a contrary side of what you're saying, that the treatment group might be actually worse off than the placebo group. But what I'm primarily worried about is just not going to be a strong enough effect size. They're not going to reach statistical significance, or it'll just be sort of equivocal or like weak trend data. I feel like that's obviously like the more likely outcome and kind of what you have to be worried about. I mean,
it's pretty overwhelmingly likely, right? I mean, it's like 95%.
As long you have to. I mean, it's got to be a small position, like just the basis of the whole thing. Phase 2.
No, I mean, I think I'm okay with saying that, with conceding that there's a 5% chance or something like that.
Yeah. But for it to do worse, I think that goes back to the prednisone thing, and I just think it's just so different, prednisone versus like a TNF.
Well, listen, I've been around medicine my whole life. I understand that they're different, but I think that
so different that it's an irrelevant comparison. Almost.
I don't think it's that different. Again, I have a decent knack for this stuff. I feel like, if you're trying to cast a general autoimmune spell on a patient, steroids are a great way to start, which is why they're approved for 52 different autoimmune and autoinflammatory conditions. So you want to say that, well, Alzheimer's is an autoimmune or autoinflammatory condition, but no, steroids don't work for Alzheimer's. Well, why? Why do they work for every single other autoimmune and autoinflammatory condition? In fact, there's, again, 52 on-label diseases for steroids. You'd be hard-pressed to find a inflammatory or autoimmune disease where it doesn't work. And TNF is the same way. Everything that TNF works for, steroids work for too. So it's an awfully, you sort of have to like dance on the pinhead of a needle to sort of make this argument work, notwithstanding that, steroids are not necessarily, pro-cognition. I'll look at the data and I'll try to synthesize that. But to me, I again, NSAIDs don't work. COX-2 doesn't work. Those are all also downstream of TNF2. There's no, in the absence of evidence, you can conclude that it's not going to work. There's vanishingly few drugs that just work out of nowhere.
It would be crazy if it worked. I guess just the one last point I would make on like the prednisone comparison is just there's so many glucocorticoid actions that aren't related to TNF.
Dude, you're talking to, I know this. I mean, I've been around medicine since I was 17. Like, I know.
The reason I don't think it's a fair comparison. I mean, there's so many like directly like against cognitive.
I've done a lot of stuff in medicine. I know this.
Right. It's a reason why the comparison doesn't make sense.
Yeah, it doesn't make sense to you. I get that, but to me, I think it's an apt comparison.
Like, why would Humira lower the risk of Alzheimer's?
It doesn't. That's a spurious.
Oh, you dispute it? Okay. So you don't believe the studies showing that there's a lower risk of Alzheimer's amongst rheumatoid arthritis?
Yes. I think it's just a spurious finding.
Like the publication is false, or what?
I think that when you examine data retrospectively, you will find things that don't replicate.
Okay.
I mean, if otherwise, there'd be lots of amazing retrospective findings that duplicated, like vitamin E and all kinds of other wonderful things that have been shown in GWAS studies. And, it's hard to sort of look at a health data and then say, okay, we found this, let's go make a drug for it. It can be done in the case of like genetics, for example, but this type of thing, in my experience, is not replicated. The lack of interest from pharma in developing drugs in this direction is kind of surprising to me. Like, I certainly would try. I would have tried 𝗬𝗎𝗓. I would have tried, even canakinumab. Like there's a bunch of drugs I would have at least given a shot. And TREM2 obviously adds another L to the whole autoinflammatory hypothesis in Alzheimer's. It seems like we don't really understand what's going on with Alzheimer's, and there's no real, reason to just chuck drugs at it for no, praying that, I randomly hit. And, the immune system is like a pretty big, pathway of nodes, and any one given node is, there's an investigator in every university that thinks that it's their node that's going to be the node that works, and no shortage of people. Well, really one person predominantly who says it's enough, but there's no shortage of people that said it was p38, and there's more people that'll tell you it's IL-1, and there's just no really great data that makes you think one way or another. So that's why the field has moved to things like ApoE, where at least ApoE there's kind of this genetic causality. Maybe it's just preclinical disease you really got to get into, but to me TNF being the holy grail that fixes everything is it's virtually impossible. But obviously if it works, they'll be in good shape. But one major question, as I'm sure you're fully aware, the Alzheimer's is one of these things where we just don't know when to treat either. So even if you had, when I remember when the Avastin phase 3 data came out, and this was an early lesson for me as an investor in biopharma, when the Avastin breast cancer data came out in 2002, they did 2 big breast cancer studies. The first was a metastatic, like second, third line study, and it failed. It just happened to come out first. And I basically took Avastin out of my model. I said it was a 0. And the first line study did great. And it just turns out that Avastin's really great the earlier you are in disease. Once you have tons of metastases, it's just not so great. And it was hard to tell. The company did the late stage study for obvious reasons, right? In late stage studies, you maybe get more signal. It just turns out that you kind of do want to go earlier in cancer. So, we just don't know when, there's a lot of people that think, in fact, most pharma these days are not even doing late stage oncology anymore in terms of third line, fourth line oncology for solid tumors, at least. So we don't know in Alzheimer's, are we missing it to the point where we're literally 10 years late and we have to focus on a PSA type surrogate where PSA, is arguably better to treat than waiting for mets or testosterone levels, for example. And, are we going to do PET imaging for Alzheimer's as the main correlate and surrogate instead of worrying about once disease is there, who knows if is TNF protective? Is it bad for you? Is it both? Is it, we just, it might be just way too late it's maybe a totally different disease at that point. Where something might actually work in that later stage, in that you're trying to preserve versus in the earlier stage. And in fact, that's one argument for TNF is that you don't want TNF in this really early stage of disease, but you kind of do want this later stage of disease. So it is one of these things where we're just blind, trying to be a blind watchmaker, and it's not easy. By now, I think you could see sort of my style of thinking. I'm a cynic and a skeptic. Why does it have to be? And secondly, why is it bad? Inflammation is a natural kind of process that is sort of a cleansing process that is supposed to restore, restore dead cells, replace cells, etc. In Alzheimer's, we could be dealing with more of a proteasome disease. It could be something that's more about impairing cellular communication. You're a little bit of feedback. But anyway, there's hundreds of bodily processes that could be, going wrong in Alzheimer's, and we don't know what it is. The easiest explanation for almost all human disease is autoimmune, and that's why steroids are so popular, and why they work. They're just miracles. The fact that the steroid label. I remember when I first read the steroid label because I always knew steroids were important medicines, but I was researching Acthar, this Questcor drug, and I had to get the label for Acthar, and they basically gave Acthar a steroid label. So Acthar is ACTH, it's just adrenocorticotropin, and it induces the release of cortisol, which is a very weak steroid. And so the label for ACTH is like 50 something odd diseases. And when I saw that, my jaw dropped because I never realized just how prevalent steroids are. They're just kind of the first line of defense for almost any damn disease. And I think that if it were inflammatory and autoimmune, we'd have a solution by now. Now there's a huge inflammasome. There's a huge, we've maybe barely sort of figured this out, and it just doesn't have to be TNF. There's NLRP3, there's NRF2, there's neurosteroids themselves, which could be interesting. There's T cells. I actually think integrin alpha 4 beta 1 or alpha 4 beta 5 integrin, those could be really exciting because 𝗕𝗏𝗏 does work in MS, and it limits leukocyte trafficking to the brain, which is, I think, really important. So, who knows? So I'm not saying it necessarily doesn't have to be an autoimmune or an inflammatory disease. It certainly could be. But, so far that's been elusive, one. And two, it certainly isn't going to come from TNF, I don't think. It might have to come from like glial specific stuff like CXCR3, CCR3, CCR4, those types of chemokine, mechanics may be more important than TNF. TNF is kind of, as it's like this just general buckshot as well. It's not that different from steroids. It largely is doing pretty opaque stuff. It's not like a JAK inhibitor where you sort of know what it's doing. Here, it's this general program of immunity. Steroids are of course broader, but still TNF is not. TNF is upregulating lots of genes. It's not like a straight shot. It's really downstream. It's this huge transcription repressor or increaser, and it ultimately has a lot of the same pathways at the end. And that's why a lot of these drugs kind of have overlapping efficacy profiles.
Yeah, I totally agree that there's probably, even if immune were to succeed and TNF was, semi-successful, I would still expect over the next 20, 30 years that we're just going to actually figure out what's wrong sort of inflammatorily or immunologically with Alzheimer's and be able to actually target it. Because even though I'm somewhat positive on immune, I still view it as a band-aid. And yes, a somewhat upstream band-aid as someone that thinks that the inflammatory process is the pathological process, even though that may be true. There's so many different ways. And like you say, the immune system and inflammation is so dynamic, and it's reparative in some contexts and degenerative in some others. So it's very tough. I really just closing remarks. As someone that thinks that inflammation is kind of what's driving the pathology, I think there's a lot of sort of supportive preclinical and just sort of logical, if you really get into the weeds and maybe have a willingness to believe. I think there's a lot there for the mechanism that they're at least trying to advance at immune. But
yeah, I don't disagree that it's an interesting hypothesis. I've in 25 years of professional investing in biopharma and running biopharma companies, preclinical data is sort of, it has to be really spectacular to me to be convincing. I'm curious, are you a buy-sider or pharma or academics?
It's buy-side. I work for a family office, actually.
Okay. Yeah. I think, there is some chance. But it's so vanishingly low that to me it's not investing, and we'll see. It could be an intelligent gamble. I don't know. I do think it'd be a big win if it does come out right.
I'm a little skeptical on even what the upside would be if it. You'd have to have the cleanest of wins, I think, which is tough because I just feel like the tenor and just sort of the general attitude towards this sort of name is demanding excellence and going away excellence. So it's tough. I've contemplated it a lot.
Yeah, I don't 100% agree with that. We could have that conversation some other time. Have you looked at Capricor or any of these other similar situations?
No, I've heard you talking about Capricor. I was talking about Alzheimer's specifically. People are so demanding, but I don't really know the Capricor story.
Yeah, no, it has nothing to do with what we were talking about. I think for immune, I have a slight disagreement. on that point, but totally orthogonal Capricor. Yeah, Capricor has got a FDA decision on 8 patients of data. It's going to be a tricky one for FDA to say yes right after the Sarepta disaster.
Right.
So that's kind of,
I don't know if you said like unintelligent bet or like irresponsible or something. I think
No.
you have a small enough position, the upside, and you know, if it actually were to somehow shoot the moon and do what it seems like it's 5% or less capable of doing, that it would maybe, I think you can justify a small position size.
yeah, I mean, I don't disagree. You know, I think it's a different approach, I think, but it's certainly not wrong. You know, there will be surprises in medicine. I mean, I can't say that. Some people say, Martin, thank you. I sold my cassava and I'm really happy I didn't lose 90% of my money.
Yeah. I mean, that was the thing where we were thinking like, you know, these big proteins really don't do well crossing the blood-brain barrier. Probably some of it does, and you don't need a lot to neutralize, because TNF is there's not a lot in the brain. But I don't know how much of that you would need to cross. But yeah, that if it doesn't even cross the blood-brain barrier, then that's even more of a reason that this drug does.
How do you activate this?
On the blood-brain barrier question, like in the Discord, I pasted that photo. I think it's from one of their patents. But you were saying that that's enough to show there is some crossing it. I just don't know that that's more than, you know, any other sort of antibody protein.
Yeah, it's not a small amount.
Yeah, because you look at like serum is like thousands of nanograms per milliliter, and then they have to like really mess with the scale to get down to like 3 nanograms per milliliter, 1,000-fold less. And that was, I think, in mice, like the 𝗬𝗎𝗓𝗓.
What was the original dose administered?
Oh, the amount that they gave the animal? Yeah. That's a good question. I have to look back at that. But yeah, it's in their methods of use.
Important. Low nanograms per milliliter is not great, but arguably it's fine. Mice are not men.
Yeah. Normally they would have just done like an ELISA or something if they wanted to measure it in that phase 1 when they drew the CSF. They could just measure the amount in the CSF directly.
I love this. Currently approved TNF inhibitors are contraindicated for neurological disease because they promote myelination and promote axon degeneration. Bro, you're gonna hurt these poor people. I think the willingness of people to believe, like just blindly believe, like published work that's not been replicated is like very sad.
Yeah, people who have not produced published work don't realize how many times you try and find a significant value and really don't correct for that or talk about it in the methods. And then, someone reads it as if it's, gospel.
You're sort of incentivized to lie because you get funding. Whereas in the corporate world, it's the opposite. You really are incentivized to make sure that you get it right because you spent $50 million, wasting money on some project, then you're never going to do another $50 million project.
Yeah, and that's like more like an MS type model. Like Alzheimer's is not this strong demyelinating disease.
Correct.
So some of this is like
axonal, maybe, axonal survival. That doesn't sound off. I don't know. Right. You're right about myelination. Okay, so is CPZ, is this time? And is the idea that, okay, look at how bad the state is. Like, this is really like cherry picked. No difference. This one has a difference. I'm just trying to figure out
those all look very similar.
Yeah. No, this one looks better for XPro, the middle one. But why isn't it better at 3 and why isn't it better at 6?
Oh, it doesn't alter demyelination, but promotes myelin recovery.
Well, irrespective, the signal should be pretty uniform. Some of these are really kind of cringe. Again, dose response problems. Let me see if I make sure I know what I'm looking at here.
So I'm trying to find the dose they used in the IP for that blood-brain barrier.
So it didn't prevent oligodendrocyte loss, but it did permit early remyelination. Like what? How would it improve phagocytosis if the whole point of TNF is that TNFR1 has a death receptor and can do apoptosis and necroptosis, whereas TNFR2 literally cannot do that. So
it's just like a lot of mixed signals about how it quote unquote works. I've definitely seen enough to make a call. I don't know if I want to write along.
10 mgs per kg.
Yikes.
That's a lot.
Yes, it's a huge amount. 10 mg per kg to get to 3 nanometers. Oof, 3 nanometers.
Yeah, mice received subcutaneous saline or XPro sub-Q 10 mg per kg twice weekly for 2 months. When administered peripherally, XPro is detectable in the brain, 1 in 6 nanograms per milliliter, which is sufficient to neutralize native soluble, that's in their paper here, through the soluble heterodimer.
Okay, so 10 mg per kg, and they're giving 1 mg here or 1 mg per kg?
In this picture?
No, in human.
Oh, in human, yes, 1. 1 was the high dose, 1 mg per kg. Whoa, so they're giving 10 times more?
Is it per kg or just 1 mg?
In humans, it's 1 mg per kg.
Okay. Are you sure?
At least that's what that picture there. Yeah, it says 1 mg per kg right there. But let me double check that.
Okay, yeah. In clinical trials like that, that's what it says. Yeah, so
Yeah,
the
1 mg per
allometric scaling is...
In humans, though, I think it's IV, right? This is sub-Q in mice.
No, I think it's sub-Q.
In human?
Yep.
Okay, so yeah. Oh yeah, via subcutaneous injection once a week for 12 weeks. In mice, it was twice a week. So would you expect that to be a lower, I mean, obviously you can't compare, human and mouse blood-brain barrier dynamics, 1-to-1, but it should have a much lower dose there, right? In the serum, if you're only giving 1/10 of the concentration. Or even less would get to the blood-brain, to the brain.
Yes. The estimated human CSF Cmax 0.4 nanograms per milliliter, but I don't even know if they're showing a Cmax. I assume that's Cmax in terms of dose. What is it says levels. Great. Levels means Cmax, but it could mean something else. More levels. It'd be Cmen. Either way. Usually when you do these things, you're trying to do Tmax, Cmax, Cmin, AUC, it's basic PK. They just never have any of this data. It just makes you wonder.
Yeah, I mean, it's going from 10 to the 4th to single digits. So
kind of
thousands.
What you would expect, I think. Right?
With a protein.
And I think that you also have differences in plasma binding, right? So plasma binding is something everyone forgets about in PK.
Amount may be enough to neutralize in the brain, even though it's a very small amount.
I think one of the problems that plagues immune investors and also cassava was this idea that the likelihood of success is very high. And one of my goals is to try to help people understand that, look, it's okay to be optimistic. It's okay to be sort of, bullish, but don't think that this is a 90% chance of success or something. And, I that's sort of when I get upset and get involved, because I don't want people to lose all their money in biotech. And whether it was cassava or any other thing, that's kind of where, I sort of step in and try to help people not, lose their shirt in something that's relatively speculative.
Yeah, I feel the same way, because I do see a lot of people that are definitely less experienced. You can tell from the way they talk either on Twitter or Discord. And as I've been sort of spending time in those spaces with Immune, it's definitely, I think it's a more intelligent crowd than the Sava crowd, because I was also monitoring that, but it's still sometimes people sort of lose sight in how difficult the disease is and just what the odds are. I would dispute 5%. I don't know if I put it at 20% or something, but it's a minority chance, probability of success, and you got to know that.
Doing work in this space is also not easy. I licensed drugs for a living and looked at thousands of drugs under CDA and, all kinds of data. And, I've also tried to replicate data published in Science and other, esteemed journals. It's very hard to believe preclinical data. I mean, it is really not that valuable. I think that the better designed the experiment, certainly you can, get a little bit of faith I really like monogenetic diseases, things like that, recapitulate the phenotype perfectly. That's one thing. But here, I mean, you have phase 1 data that's really, not so clear. You know how I feel about retrospective data. Again, if you could find a replication of it that was prospective, I'd be really curious. Or even multiple retrospectives is not horrible. But outside of that, you're looking at, that little Enbrel study, not a whole lot to go on. The lowering of cytokines by 15% seems very modest to me. There are some questions about BBB penetrance, which are interesting. They haven't really shown blood-brain barrier data. I have a copy of the protocol, which I found online.
Yeah, I saw you had that, and you had the exact powering in the study, which I thought was really interesting. It made me a little worried about the EMAC, even more so than the CDR, because you went through, and there's only one data point with the Tango study for EMAC,
there's no way it can work, I think, and on the EMAC side, but whether or not they could try to spin it is another story. But EMAC seems like a just a foregone conclusion that they aim too big, and just use common sense. I mean, ultimately a 200 patient Alzheimer's study is not a good idea. Could it give you some signal? Sure. But, it's probably not great to do some p-value work there. But I think the investigator's brochure is going to be really valuable, because that actually has some of the preclinical data and what happened in phase 1, which, heretofore has really not been made clear. And it's been cherry-picked, and it's been kind of wishy-washy. So that would be really interesting to get a hold of. I don't try to get MNPI, so that thing it is publicly available if you look hard enough. So it's right on Google. You'll find it if you're crafty.
I try. Yeah.
It's not too hard, and I'm happy to show you how to get it. Anyway, stay in touch if you can.
All right, cool. Good to talk to you. Hope everyone got something out of that.
Yeah, likewise.